Dr. How Dr. Heather Cruzy is an accomplished psychologist and faculty member at the University of Kansas Medical Center. With expertise in clinical and health psychology, Dr. Cruzy is dedicated to improving mental health and has extensive experience in psychotherapy, clinical training, and mentoring. She has been an influential speaker at conferences and has received recognition for her contributions to the field. Her commitment to mental health and patient care is evident in her impressive career. Thanks, Dr. Cruzy. Welcome.
So I'm going to be talking to you all today about destigmatizing suicidal ideation. So specifically, things that I'm going to be going over are, is suicide quote unquote contagious? How common is suicidal ideation? How does stigma influence people's help seeking behavior? And then last and most importantly, how can healthcare providers intervene if they have patients who express suicidal ideation? But before we get started, we're going to have a little pop quiz. So, true or false? Asking about suicidal ideation will increase the chances that a person will attempt suicide. Y'all are good. False. So, this is a myth that still persists, unfortunately, and it gets in the way of healthcare providers openly talking about suicide because they're afraid, what if I put an idea in someone's head? And we know from the research that that's not how it works. Only trained mental health providers should address suicidal ideation. Good job. I figured you all would get this one because you're here today. But, talking about suicide is hard for a lot of people. Um, and I know many healthcare providers have told me over the years that they got hardly any mental health training. So they really don't feel equipped to have these conversations when they come up with their patients. Someone who's suicidal will not openly discuss it. False, correct. So this is another myth that gets in the way of healthcare providers intervening when people talk about suicide. Many people who have suicidal ideation will kind of go back and forth on how intense it is, how much they think about it, how seriously they think about it. And sometimes by having conversations, it can help people to sort out their commitment to life. And so this one is probably pretty obvious given what we just talked about, but suicidal ideation can change from moment to moment. True. So that's why reassessment is so important. I'm not sure what all of your, if you're a clinician in here, what all of your clinics look like. Some have very good routine suicide screening, some don't. But there's going to be times when, even outside of formal suicide screening, that healthcare providers are going to need to talk about these things. So, the first thing I want to talk about is whether or not suicide is contagious. And the reason why I want to start here is because there are ways that we can destigmatize suicidal ideation and destigmatize mental illness. There are ways we can talk about it that are helpful, but there are also ways that are unhelpful. And I think that we have to be honest about that and mindful of that. So, the first thing that I want to focus on is social contagion. So, in the last presentation, you heard Greg talk a lot about social learning, and that is very true when it comes to suicidal ideation and self harm. Humans are creatures who learn from others, even if it's not an obvious or explicit lesson. We learn from watching other people and seeing what is normative or not normative. So that makes it sometimes challenging to talk about raising mental health awareness, openly discussing suicide, because many people, understandably so, are afraid, how can I normalize this without making it sound like I'm endorsing this. So, there is something called the Werther effect, which is also known as copycat suicides. And you all are probably familiar with what we call point clusters. So, this is when you have an increase in suicides within a specific time frame and a specific space. So, for example, in a school system, if a student dies by suicide, the risk for all the students goes up. And we do know that this happens. Um, the research on youth suicide, so adolescents and young adults, the information varies, but it's suggested that anywhere from 2 to 13% of youth suicides are due to this social contagion. So we do have to be mindful of that when we're talking about suicide and when we're talking about people who die from suicide. How do we do it in a way that is helpful and not increasing people's distress? There's also something called mass clusters, which is suicides that increase within a certain time frame, but not necessarily within a specific space. So, for example, when you have a celebrity who dies by suicide, people who are connected to that celebrity in some way, like maybe they're a fan of them or they follow them, they may be at increased risk of suicide. So, now that we've got that out of the way, the opposite of this is something called the Papageno effect, and I may be mispronouncing that. But this is the idea that we can report on suicide and talk about suicide in communities and in school systems in a way that is honest but hopeful. So, for example, the media, the news media, is most likely to report on stories that make people angry or scared because that keeps people engaged with whatever media is being consumed. So that means that we don't get a lot of, good news stories because that doesn't keep people turning in. But when we do get media that report on people who've experienced suicidal ideation but did not attempt, people who found ways to cope with the crisis they were going through, and also provide examples of healing and resilience. That can be very therapeutic for people because they can see, okay, I can be having this crisis right now, but that doesn't mean it's inevitable that I am going to end up dying by suicide. There are other ways out of this. It's also valuable to debunk myths. So, like we did a few minutes ago, because a lot of these myths make people just very scared to even discuss suicide openly. And then that becomes more stigmatized when something is like secretive. It's helpful to normalize mental health problems so people know what to look for. They know what signs and symptoms often occur with things like major depressive disorder when people are feeling suicidal, so they can recognize, oh, this is what I'm going through, or this is what my family member is going through, or my colleague is going through. And we want to have focus on preventative programs. So instead of just talking about how suicide happens and who it happens to, we need to make sure that we are getting the message out of what can be done to prevent suicide and who to call. So the Suicide Prevention Lifeline is such a great resource because it's available 24/7 every day of the year. And now, because it's only 3 numbers, it's very easy for people to remember. So it's simple to let people know this is a resource that is literally always available. And last, when we focus on suicide research and focus on the facts. So here's who's affected by suicide. Here are warning signs, and here are treatments that we know can be helpful for those individuals. So I assume that no one in here is a journalist, but maybe I'm wrong. But there are guidelines put out by national and international organizations about how we can talk about and report on suicide in a way that is beneficial. And even if you're not a media person, I think that these guidelines are still applicable in whatever settings we work in when we talk about suicide. And I also think it's valuable to keep these in mind when we are consuming media. So when we're reading about or hearing about suicide that has happened. So, things we don't want people to do. We don't want the no comment because that stigmatizes it more. It also opens up speculation and creates like this um, aura of secrecy around what happened to a person who died by suicide. It's not helpful to attribute suicide to a single factor or decision. So, tying in with that, we don't want to ignore or minimize the connection to mental health problems. There are, of course, cases of people who attempt suicide in an acute moment of crisis where, as far as we know, they didn't have any suicidal ideation before that. But for most people who attempt suicide and die by suicide, they do have a mental health history. And that's important to note because that means we can intervene sooner if we can recognize what people are going through. We do not want people to glorify suicide or the deceased. So we see this with celebrities, of course, but also, in communities and school systems. If someone dies by suicide, it is understandable that people close to them will want to glorify that person, but we're all human, right? We all have good things about us, we all have bad things about us, we have a lot of neutral stuff about us. And you don't have to talk badly about the deceased, but you also don't have to put them on a pedestal. It is not helpful to have repetitive coverage, which in today's media world is like impossible because we have 24/7 news stations, we have social media. So, what this means is that you, as the consumer of media, need to know when to turn it off because you can get sucked into story after story. I'm sure we've all been reading a news story and then another one is suggested that's related and we click on that and then it's an hour later and we don't know where our time went. So we need to be mindful of that kind of thing and make sure that we know when we need to turn it off for our own mental health. Do not want to have unnecessary details. So related to that, we don't want sensational to be sensational. There are places in the world that currently restrict journalists from reporting on suicide because in other places in the world, such as the United States, we don't have good guidelines. And so sometimes there is irresponsible reporting where, like, a news article will go into great detail about how someone died and essentially provides what we would say is like a how to manual. That is obviously not helpful. And of course, we don't want anyone to repeat myths. So, how does this actually play out in the real world? Um, Most of you, I assume, recognized the individual on the slide a few slides ago was Kurt Cobain, and he died from suicide in 1994. There was a lot of worry at the time about the influence of his suicide. Like, would there be an increase in suicides, especially among his fans and young people? But that actually is not what ended up happening because his community in Seattle did a really good job of addressing what happened in a respectful and honest way. So they had a public mourning and vigil, which is, not uncommon when a celebrity dies. But at this vigil, there were tapes played of Courtney Love, who was his wife, um, reading segments of his suicide note, which, like, for the record, is actually not advised because that can end up glorifying the person who died. But in this case, it was considered to be very hopeful because it was obvious how distressed and upset and angry she was and the impact that his suicide had on her and had on their daughter. And regardless of how people feel about Courtney Love, she has been praised over the decades for continuing to speak out and talk about how her husband's suicide has continued to negatively impact her life and the life of their child. Also, though, at the public mourning, they disseminated information on warning signs for suicide. So they let people know, hey, this might be something that you need to be aware of for yourself or for your loved ones. And the Seattle Crisis Clinic did a really good job at that time, not just at the vigil, but in a lot of media reports of letting people know we are a resource. Come to us, call us. If you notice that you are feeling any of these things, we will be here. And the cost of their clinic increased substantially in the weeks following his death. So people were utilizing that resource. I don't know if we can't know this for certain, but there's actually been research studies trying to figure out was there a contagion effect with him? We do know there was one suicide at that time, I believe in the Seattle area, that was directly linked to Cobain. He referenced him in his suicide note. But in general, suicides did not increase in the weeks following Cobain's death. So that is very optimistic that we can talk about something like this that occurred, that was tragic, that affected lots of people, but that doesn't necessarily mean that we're going to have this contagion effect. So, one last thing on this. What about fictional accounts? TV shows, movies, books. You probably all have heard of 13 Reasons Why. It's a controversial Netflix show that's based off of a book. And full disclosure, I've not seen the show, I've not read the book. But at the end of the first season, there was apparently a very graphic 3-minute presentation of suicide. And it was actually taken off a couple of years later because of the outrage about this. So I spent a lot of time looking at the research about what kind of influence this had. And in short, there's a lot of conflicting opinions and data. There's some studies that say, yeah, there was a contagion effect. There are some that say there was absolutely not a contagion effect. So it's unknown. But what you do know, like in factual terms, is in the weeks following the release of the first season, Google searches for the following terms increased a lot. So in some ways, we're obviously seeing there is this influence of people like wanting to know more about how to die by suicide. But there's also an increase in people looking for resources. So even with our Google searches, we're still not quite sure like what the net is here. So in summary, for our first question, is suicide contagious? Maybe in some cases, especially for young adults and adolescents, especially for people who are similar to the person who dies by suicide. So maybe it's a peer, maybe they're in the same age group, the same demographics, but it doesn't have to be. So the way that we talk about suicide, not just in the media, but in these settings and with our patients can really matter and make a difference. So moving on to our next question here, like how common is this? If you're a healthcare provider, are you going to see patients in your practice that have suicidal ideation? Well, this is probably not new information to anyone, but since the advent of antibiotics and up until 2020 with the pandemic, these were generally the top 10 causes of death. Like there wasn't much change year to year. And suicide was the 10th. It's also worth noting that suicide is probably underreported in these types of statistics. There are most certainly cases out there of people who died by suicide and it was classified as an accident because of the way that we get mortality data. So this is something that influences lots of people. So even if you work in, for example, like a heart clinic, you are going to encounter people who are having suicidal ideation. So we need to at least know, like, the basics of what questions to ask and what kinds of interventions would be helpful. So, some brief statistics. The people who are most likely to die from suicide, not necessarily attempt, but die from suicide, are men over the age of 45 who are non Hispanic whites who did not complete high school, also people with less social support, and if you'll notice here, people with other general medical conditions. So I work at a cancer center, for example, and the risk of suicide among cancer patients is at least twice of the general population. We also know that people post heart attack have an increased risk for suicide. So you are going to see people in your clinics, whatever they are, who are experiencing suicidal ideation. I think it's important to note, though, that most people who attempt suicide don't die by suicide because I want to just keep in mind, like, it's not hopeless. Even if you do have patients who attempt suicide, that doesn't mean that it is going to be the end for them. So, putting it another way, in 2021, for every one person who died by suicide, we had 3 hospitalizations for self harm, 8 ER visits for suicide, and 38 suicide attempts. Also, there were 265 people who seriously contemplated suicide. Keep in mind that whenever we are surveying something like suicide or mental health or drug use, the numbers are most certainly underreported due to something called the social desirability effect. People are, even when it's an anonymous survey, people are less likely to report things that might be considered controversial. So there were probably a lot more people who are not captured in this data. So overall, in 2021, people who seriously contemplated suicide, about 5%. Now, that doesn't even take into account people who contemplate suicide or have what we would call passive suicidal ideation, which is like a wish to die, but not actively planning to die by suicide. So these might be your patients who say, I'm not planning to kill myself, but if I went to sleep and didn't wake up, I would be fine with that. So that percentage is going to be much larger. Something else to keep in mind is that things are different by age group. So, for example, among young adults in 2021, about 13% contemplated suicide. About 5% made a plan, and not quite 3% attempted suicide. Now, you might be thinking, I thought you said just a minute ago that the people most likely to die from suicide are over the age of 45. That is true. So there's a couple of different ways we can look at this. One might be that, fewer people as they age contemplate suicide, but the ones who do are more likely to act on it. It could also be that, people as they age are less likely to be honest when asked this question for whatever reason, maybe stigma, maybe other things. But what this tells us, and the point of me belaboring this, is that we can't know what the person in front of us is thinking or feeling. We can't assume just based off of their demographics. We can't be like, well, they're female, they're age 30, they have a good support system, so they're probably fine. We don't know. So in summary, how common is suicidal ideation? It is common enough that you're going to see it in your practice. However, just to reiterate, most people with suicidal ideation will not attempt suicide. So a lot of times healthcare providers will tell me that they're like worried about talking about suicide because like I quote, I can't talk someone off a ledge. I've heard that multiple times. You don't have to. None of us have to talk someone off a ledge. But we do have to identify people who might be at risk and get them the resources that they need. So, our next question here: how does stigma influence our patients, seeking help? So, this probably goes without saying, but stigma is a public negative stereotype that oftentimes people internalize. So, when it comes to stigma related to suicidal ideation or mental health problems, there's research that shows that cultures where boys and men are taught like don't show emotion, tough it out, that leads to stigma. Stigma is also in the United States, at least, influenced by how the media portrays suicide. You're more likely to see a news story on a murder suicide than on a suicide. And murder suicides are not that common and they're not typical, but it creates this media image and this cultural image of what suicide looks like when that's not actually the case. Also, suicide prevention is very often misrepresented in the media. And I see this in my own practice. When I first meet a patient, I go through all of the limits of confidentiality, et cetera, et cetera. And I also talk about how many people have suicidal ideation, but they're not planning to act on it. So I don't want you to think that if you tell me, yes, I think about suicide, that I'm going to call 911 and have you go to the emergency room. I have had people in the past, before I gave this caveat, tell me later, I was afraid to admit this because you said if, I talked about suicide, you might have to break confidentiality. And I'm not planning on committing suicide or dying by suicide, but I do think about it. So I realize that we even when we're talking to patients, we need to let them know most of the time, if someone is expressing suicidal ideation, we are going to provide them with resources and help. It is very rare that someone would need to be involuntarily committed. So, how does this impact our patients? Well, it probably is obvious, but it decreases the likelihood that an individual is going to seek help. It also creates problems with people recognizing their own and others' mental health symptoms. So, they might not even know, oh, I should be seeking help for this. It is unfortunately connected to increases in suicidality, potentially because people feel helpless or hopeless or have a lot of self blame and shame. And we see this especially in males, those with less exposure to suicide. So, not necessarily just people who have never known a person who's died by suicide, but people who, haven't, been presented with facts on suicide and suicide prevention. Older adults, those with less education. So I took this slide. This is from the annual surveys on mental health and substance use. And the highlights are my own. But this is 2021 individuals with mental illness or a perceived need for mental health care who didn't get it and the reasons why. And people could choose more than one option here. So probably adds up to more than 100%. But you'll notice a lot of the reasons people put here are related to stigma or other people finding out. The last one, it just explicitly says, I don't want other people to find out. So these are individuals who have identified, I do need mental health treatment, but I didn't get it because of stigma. So, in summary, how does stigma influence help seeking behavior? This means that when we have patients in our clinics, whatever type of clinic it is, who openly talk about suicide, who acknowledge that they're struggling, we cannot assume that they're ever going to disclose that again to another healthcare provider. It can take a lot of bravery for people to be honest about that. And we can't think, oh, well, they even, if you're like at KU Med, we can see like all of a patient's appointments in the system. Even if you see, oh, they have an appointment with a psychologist next week, I'm sure that person will address it. We don't know that. We don't know if the patient will talk about it next week. So we can't ignore it when it does come up. All right, I'm trying to be mindful of time. So, our last key question here, and the one that is most important, is what do you do? Like, what if you work in a primary care setting or a heart clinic and someone talks about suicide? So, it's important to note that multiple studies have found that of people who died by suicide, about half had seen their primary care doctor the month before their death, but very few had seen a mental health provider in the month before their death. And this is really, really unfortunate. Um, Even if we had all the psychologists in the world, all the social workers and mental health providers in the world, because we all know that there's not enough mental health providers available. But even if there were, many people still wouldn't seek out that treatment for a plethora of reasons. Even after a suicide attempt, research has shown that about half of individuals still don't get mental health care. This is especially true with older adults. Older adults are less likely to seek out mental health treatment, but interestingly, they are like more open to talking about mood and suicidal ideation and problems like that with their primary care doctors. So, for some primary care doctors, that might be the first and only, line of defense when it comes to suicide prevention. That might be the only opportunity. So, what do we do? Well, according to the CDC, we have to do a lot of things. It goes on. And this is all true. Like if you look at this and study it, you'll see this is a cultural problem that one person, one provider is not going to be able to fix. And no one expects one person to fix it. However, we can all play a role. And where we all have a role, most of us in this room, presumably, is under here as gatekeepers. So, what the CDC means by this is people who are likely to be like public facing and trusted, such as primary care doctors, teachers, religious leaders. Those individuals should be given extra training to screen for and deal with suicide. Because, someone might talk to their priest about suicide, but never a healthcare provider. So, if you're in a clinic that, screens for suicide routinely, but, once a year or doesn't screen at all, like how do you know when you need to ask more questions? So, some warning signs, obviously talking about wanting to die or killing yourself. People who talk about feeling trapped or having nothing to live for. Hopelessness is highly correlated with suicidality. Talking about unbearable guilt and pain and revenge, and lack of communication and withdrawal. Some behavior cues, which you may not see, like with the patient in front of you, but which they might report or their family or caregivers might report, could be like the person is more agitated or anxious than usual. They seem to be using alcohol and drugs more. They're sleeping like a lot or too little. As Greg talked about, sleep is so valuable. When a person is chronically sleep deprived, they're not going to be making decisions that they would make when they had a good night's rest. online searches, which you're obviously not going to know as a healthcare provider, but their family might tell you. Like, I noticed that they were searching for these things. And then, acting reckless, like not doing things, basic things like putting on their seatbelt or driving the speed limit, things where it shows there might not be as much of a um, goal to protect their life. So, the three M's, according to a prominent suicide researcher, motivate the patient, mean safety and monitoring. So, what does this mean? So, motivate, if you have a patient who's talking about suicide, obviously we always want to ask, like, what are reasons why you wouldn't want to commit suicide or die by suicide? What activities or people would the patient miss? And this doesn't have to be like big life events. Often when we talk about this, we think of like, oh, I want to see my children get married. I want to meet my grandchildren. I want to retire, travel the world. It can be small, everyday things. Like sometimes patients will say, oh, I'm really looking forward to this movie that's going to be released in December. Like I would like to see that. So it doesn't have to be like big, huge things that might motivate a person to, continue to commit to life. I think it's also helpful to ask, like, what if treatment could help? So you might have patients who have tried treatment in the past and it didn't work at all. Or maybe they had a therapist that they did not connect with or they didn't feel heard by. And that is unfortunate, but it's a reality. Like therapists, we're human. Sometimes, for reasons like unknown, you get along better with some humans than others. That doesn't mean that all treatment is going to be unhelpful. So, what if you tried something different? What if you tried a new therapist? What if you tried a new medication? There's a lot of psychiatric medications. So, even if you tried one SSRI and it didn't work, that doesn't mean that all SSRIs will not work. What if your circumstances improved? So, sometimes I will ask patients, do you want things to change or do you want to die? Because sometimes people are in a situation where if their circumstances, whatever they are, improved, they would like be very motivated to live. Versus someone with chronic depression might not be able to still identify reasons for living. And I encourage patients to be curious about the future. You don't have to be hopeful. You don't have to be optimistic, but just curious about what could happen. What if things got better? And sometimes patients will say, like, well, maybe I will commit to the next couple of months because I could always attempt suicide later, which is, sad and morbid, but it does give you like this window of time to work in to say, okay, like it's true. If you could die by suicide at any time, why not wait and see if things are better next month, next week? There's also this concept of a commitment to life agreement, and I am running low on time, so I'll try to be quick. When I was in graduate school, we learned that if a patient is suicidal, you should have them, quote unquote, contract for safety. Are any of you all familiar with that term? Okay. It doesn't work, unfortunately. Contracting for safety is like sometimes literally a contract that the patient signs that says, I will not harm myself between like this appointment and my next appointment. Sometimes it's a verbal agreement. There is no evidence that contracting for safety actually changes people's behaviors. What does change people's behaviors, though, is like commitment to life. So instead of focusing on what the person is not going to do, they're not going to harm themselves, focus on what they will do. And you might be thinking, well, how? Or I don't know how to do that. But like with everything, there is an app. There's many apps. This is a pretty popular one created by the VA called Virtual Hope Box. It allows people to upload photos, things that remind them of why they want to stay alive. It helps them to create their own coping skills. And even sometimes maybe those things don't work. You just need a distraction. It has distractions, it has relaxation techniques. There are many other apps like this as well. But I would encourage you all to look in your app store, see if this is something that, would be helpful for your patients or if there are similar ones like this. Then we want to talk about means. In other words, removing access to lethal means. And the reason why this is so important is because of people who attempt suicide but live, many will report that even if they had thought about suicide on and off for a long period of time, by the time that they decided, okay, I'm going to do this, and they act on it, it's less than 10 minutes. So anything we can do to slow that down to get the person to, not be in that acute crisis mode might save their life. This is why the suicide prevention hotline is so helpful, because even if someone, calls the hotline and is still depressed when they hang up the phone, just having some time to have their mind be cleared a little bit can make the difference between life and death. If a person decides that they want to use a firearm, having to go unlock, the gun safe, then having to go get the ammunition elsewhere, all of those steps that they put in the way will slow them down and give them the opportunity to reconsider. And then last, we want to monitor. So, depending on how often you see your patients in clinic, maybe it's once a year, maybe it's once every 3 months. We don't want to assume like, okay, I had this appointment, we worked out this thing, and 3 months later they come back and they seem happy. So I don't want to bring them down. We can't assume that they're happy, that things are okay. So we want to reassess, and we want to ask about like not just are you having thoughts of suicide, but how often? How intense are these thoughts? What's the duration? Is it like a passing thought, or is it something that you're ruminating on all day, every day? And if possible, enlist family and friends and social support. I think it's important to reiterate here that psychiatric hospitalizations, they are sometimes necessary, but they're not the standard of care for a lot of reasons. For most people who have suicidal ideation, but they're not making a plan, they're not intending to act on it, being involuntarily hospitalized will not be therapeutic or helpful. So, a few final thoughts from me. Do not, if a patient tells you that they're having thoughts of suicide, don't assume someone else will address the problem. Don't think like, okay, well, they're going to see the social worker, so I'll just, pass it off to them. Don't leave the person alone in the room without having a basic plan. And what I mean by this is like someone talks about suicide. Maybe you have a social worker across the hall that would be better equipped to talk about this. Like, that's great. But make sure that you have a way of contacting that social worker, that psychologist, that case manager to come into the room before you leave the room. Because since we know stigma makes it hard for people to acknowledge their thoughts of suicide, if you leave the room, that is the opportunity for the patient to decide, actually, I don't want to deal with this, and they can leave. Don't provide empty platitudes. No, don't say suicide is a permanent solution to a temporary problem. That's really invalidating. It also really minimizes that. For someone who's contemplating suicide, it does not seem like their problems are temporary. Don't say it will get worse before it gets better. I witnessed a psychiatrist say this one time to a patient's family member when I worked in an inpatient hospital. And the family member looked that psychiatrist right in the face and said, "What does that even mean? Like, what are you trying to tell me? What are you doing for my child? How are you helping them?" And that stuck with me. So make sure whatever you're telling patients and families actually has like some value. Don't say everything happens for a reason. If you have patients who have that belief system, that's great. You can validate that, but we don't want to put that on someone. What these platitudes tell people is, I'm uncomfortable. I don't know what to say. And I want to be able to say something quickly that will wrap this up and will make me feel like I said something. Here's what you should do. Listen. No, I'm a psychologist and have been for a while. And I am still really um, grateful when I, hear from patients just how therapeutic having someone actually listen to them is. Um, Ask questions. We don't want to assume if someone says they're suicidal that they're going to go out and try to die by suicide. You can validate a person's emotion without agreeing with their worldview. So, an emotion word is one word: happy, sad, confused, overwhelmed. Sometimes in our culture, we say things like, I feel like blah, blah, blah. That's not actually a feeling or an emotion, that's a thought. So, you don't have to agree with what they're thinking, but you can acknowledge, yeah, you have a lot going on. You're really overwhelmed. That's understandable. We want to assess their needs. And sometimes the thing that you can do that's best is giving them the suicide prevention lifeline and helping them get connected with mental health services. So, in summary, you're going to see patients who have suicidal ideation. It's all of our jobs to address it. And mental health is health. So, we can't separate a person's mental health from their physical health. It's all of our jobs. Right. I'm not sure if we have time for questions, but thank you. Oh, we do? Yeah.
All right. Does anyone have any questions? You got to use the microphone. Oh,
I don't know if you have any thoughts on this, but speaking of stigma, I've seen a few articles and commentaries on not saying the word commit suicide, and I didn't know if you had further thoughts on that, or if there's been research or studies on that.
That's a great question. You probably noticed that a few times I said commit, and hopefully I corrected myself every time, but maybe not. I don't know what the research says on it, but I do know that, in the healthcare field, we are trying to get away from that because it it has a value judgment that is unnecessary. So saying, die by suicide is factual and it doesn't give any type of commentary on the person dying by suicide. Yes, that's a good point too. So for those who didn't hear, she said commit is also associated with crime. So, that will obviously lead to more stigma.
Like very kind of negative connotations as well.
Yeah. And you will encounter people such as myself who are still trying to update our language. And feel free to call people out when you notice that they're using outdated language.
all right. We have time for one more question.
So we recently, the number may be different, but we recently were notified of two physicians that weren't necessarily in our health system, but tangential to our health system. And we only knew because others had told us that they had died by suicide. And when you're looking at, we went out to look at their obituaries and, the notices out there. And so is there a way to talk to families about how important it is? I mean, maybe it's they're not ready, that's where they're at, meet them where they're at about it, but just that again advocating for talking about it so that people know that it's out there and that it's happening.
I appreciate that question because you will see in obituaries sometimes the absence of a cause of death. And that kind of is like the no comment thing from earlier. Or, it will be kind of something vague, but people will do so much to dance around the word suicide. And for a grieving family, they get to make the decisions they make about talking about suicide and publicly talking about it. But I do think like culturally and like within our workplaces, letting people know we can talk about this. It is not a moral failing of the person, of the people connected to them, you know, and if we can be more honest about it, then we can give support to those families better. Every now and then you will see an obituary that maybe like makes the news because people are very good about being honest about their loved ones' issues with mental illness that culminated in death by suicide. And I think that those types of obituaries like go viral, for lack of a better term, because it's so uncommon and it's really refreshing for people to see, okay, we can still love and honor and respect this person without having to ignore that they also had mental illness that led to their death.
All right, thank you, Dr. Cruzy.
More specific, drilled down training in safety planning and assessing suicide risk that incorporates culture. There is a training offered through Community Connections. It's called Suicide 2.0.
Oh, you're talking about the advance. There's the Be Sensitive, Be Brave, and that's kind of an introduction, and that's for anyone regardless of your background. But then there's the Advanced 201 training, and that's specifically for mental health professionals if you're wanting more advanced training on not just suicide prevention, but collaborative safety planning, documentation, and then treatment. Okay. All right.
Sorry, I know we went over a couple minutes. I apologize.
And I don't know if do we have time for questions? Sorry. Okay. Think we have.
I would just like for you to repeat the last about the collaborative safety planning. What is that called again?
So that is through the company called Community Connections, and they have an advanced 201
2.0,
or two.
or is it 201?
It's 201.
Oh, yeah, 201,
Advanced
sorry.
201 suicide training.
No, there is a cost associated
There's
with
a
that.
cost. With both of them, actually.
With both of them, yeah. But it does provide CEs for mental health providers. It is a great one, and it's actually done by Joyce Chu, who is the researcher who created who is one of the creators of the culturally informed, or the cultural model of suicidality.
And it goes into specific details about the collaborative safety planning, how you want to document risk, take into consideration static and dynamic factors, and treatment, depending on who's presented in front of you. So.
I've often found that when assessing someone for suicide, the level of comfort or discomfort with those thoughts gives you something to get started on.
Mm-hmm.
Yeah.
The other factor is from a cultural standpoint, if since I supervise residents, if the resident is the first one in the family to achieve that status, but their culture is one of the male head of household is the final say, or to be polite, it can be a hindrance and a stumbling block for them.
Yeah.
I started out in child psychiatry. One of my first patients in training was an 8-year-old boy. He was white. His father was 25-year military, French-speaking part of Louisiana. That man could not call me doctor to save his life. And the kid was stuck between us. The kid couldn't even play with black chess pieces. That's how hard it was. So my work was not only on his anxiety and depression, but being okay with me.
Yeah.
So
yeah. Thank you. Yeah, that adds a different layer to it, right? That we, certainly couldn't touch on within this, but obviously we take in mind the cultural factors of who's in front of you, but we also have to take in mind ours, like who we are in that space and how that impacts potentially
how we view these things, how we think about them. I did not mean to interrupt you. I apologize. But also the stimulus value that we bring.
Yeah.
And how that's going to play into the relationship.
Absolutely. All right.
Thank
Well,
you so
thank you so
much.
much.